Are you an entrepreneur or ready to become a boss? Welcome to Hawaii Boss, the business podcast made in Hawaii, where you will hear from island movers and shakers on who they are and their impact on our state. And now, step into the office of your host for Hawaii Boss, David Pettijohn.
Aloha, Hawaii Boss podcast crew listening in out there. This is David Pettijohn, your host, and you're listening in this week to a very special guest, a colleague of mine in the healthcare profession, Dr. Toby Smith is a doctor of osteopathy, or osteopathy, excuse me, and he's also specializes in geriatrics and care for seniors. He also focuses in on palliative care or end-of-life care and compassionate care during those times. We're very fortunate to have on with us Toby Smith. We're going to find out a little bit more about him today and also his passion for the work that he does and his passion for the work that he does in Hawaii. He's a Big Island guy on the Kona side, but he works, most of the doctors around have to work and do different rotations around and maybe some hospital weekend, hospital ER work. But anyway, we're excited to have him here and listen in, talk about what's going on with nursing homes now related to COVID and vaccinations and the different things that are going on. We're just very fortunate to be able to have him with us today. Everybody listen in and enjoy this visit with Dr. Toby Smith. Aloha, Hawaii Boss podcast crew listening out there again to another wonderful week of interviewing the boss as we go into their office and try to find out a little bit more about how we in Hawaii get through this pandemic, move on and rebuild. So we're talking to some professionals today. We're very fortunate to have in our office. We're over in his office on the Big Island. His office is on the side of a beautiful mountain, Hualalai. And we are very excited to have with us Dr. Toby Smith.
Thank you. Yeah, it's a pleasure. It's good to see you, David, and looking forward to this.
Sure. Toby, a little bit more introduction about you. You're a physician. There's a DO. People are used to seeing an MD. What's this DO versus MD? You can still treat, you do all the things, same things the other doctors. Can you enlighten us a little bit about that? Because we're all curious.
Yeah, sure. So there are two main types of medical school. There's the allopathic medical school, which gives you an MD degree, and then osteopathic medical school. So the main difference is we get a little bit of extra training in osteopathic manipulative medicine. So some people would kind of correlate that to what chiropractors do a little bit. We focus a lot on musculoskeletal disease and how to treat those from a non-prescription standpoint of prescribing medications, but more adjustments to the spine and different musculoskeletal techniques. Okay. So we go through, in medical school, we learn about those additional techniques to offer to patients.
Well, that's awesome. So that's, again, I don't think it's as much now, but there used to be this, divide, or as this came out as a format of becoming licensed as a physician, the MD school, of thought may have their opinions about things. But again, from my perspective, it appears that the quality is just the same. And so I'm sure there's some debate about that amongst your peers, but your specialty is in something a little bit different. And that's why a little bit more about you is that you are also a certified medical director and geriatrician so then you work mostly in nursing homes and care homes. There's also, you have this palliative care certification as well. It appears you've worked with seniors for most of your career. What kind of shaped that part of your career? What led you to these types of endeavors in the healthcare field? There's so many different ways you can go in as a doctor. What leads you in this path?
Yeah, for me, it all started kind of in my upbringing. I was born and raised in California, and lived about 5-10 miles away from my grandparents. And
so California is big. Where there's a lot of people maybe listening out there. California, southern, northern.
Yeah, Southern California, so San Diego area.
Okay.
So yeah, I grew up there, and pretty much every week would be over at my grandparents' house, and had a close relationship with them. And they both ended up in nursing homes toward the end of their life. And when I would go to visit them, I would go into the nursing home and just kind of be curious where the doctor is, and they were never there when I was there, and it always seemed like they were kind of non-existent. And I thought, they're in a healthcare facility. Where is the doctor? Why aren't they here all the time?
Right.
And so that kind of led me down the pathway of getting involved with research in nursing homes as I went to college and graduated from college, and doing research in nursing homes. And so that triggered me to go into medicine, internal medicine, and then out here in Hawaii to the University of Hawaii for their geriatrics fellowship program.
Yeah, and that's at the medical school here. That's one of the premier geriatrics rotations, isn't it? In the country. I mean, it's well known.
Yeah, very, very well known. And that was really the reason I had come out to Hawaii, because of the reputation of the Geriatric Fellowship Program, and just the people that have been involved with that program over the years, and the development. I had actually, when I was at UCLA, had been recommended to go to UH for geriatrics, because there was actually a separate department. Most schools and residency programs have geriatrics as a subdivision under internal medicine, and University of Hawaii actually has a completely separate department of geriatric medicine. So
yeah, and they've done very well for themselves. I know that they are also provide services to nursing homes currently out in the community, which is again, they're very involved in the work of that you do, but it's special. It's sort of a specialty that you do. So as a physician, and we kind of briefly glossed over, I want to go back a little bit. You did some research in nursing homes in undergraduate school. What did you study in undergraduate study, so that, were you knew that you were going to be a doctor, or what?
No, I actually started off going the direction of more physical therapy. My degree was in sports medicine.
Okay.
I went to Pepperdine University and had my bachelor's, but actually that's what connected me to UCLA, is that they had research going on doing exercise and incontinence training with nursing home patients. And that's where I got involved with taking care of patients, getting them up to walk with them, exercise with them. And
see, I knew there was more to the story here. We kind of just suddenly, it was your parents or your family members that were, that suddenly didn't have a doctor around, but there's more to it. It seems like you were just always engaged in this way.
Yeah.
But then you were in, so you thought, okay, you're going to go this therapy route, but then there was this other opportunity, this other thing that, what tuned you into this medical director, or not medical director, but the becoming a doctor, sort of, when was that switch?
Yeah, I think it was when I was actually doing research and working with the patients in the nursing homes one-on-one on a daily basis. It was kind of like a CNA role. And you really got to know the residents of the nursing home on a day-to-day basis, and they got to know you, and just developing that relationship with them, and then realizing that they had some significant medical problems that, not that they weren't getting addressed, but that I felt we could do a lot more from a medical standpoint and physician involvement. And so knowing, the point of the research was really to look at the medical effects of exercise and taking care of nursing home patients. But as I got more involved, it became more how much more we can do to take care of the elderly. And, if they're in nursing homes, what can we do to take better care of them there?
Right, or wherever. I think the the whole goal has become, as I've grown up in healthcare and in nursing homes and things, is that as you know, the lower level of care, the more independent location that possible is where we want folks. We want, and home is the best place, guaranteed. So we've learned things over time, and but comes a point where sometimes, because the needs or, you know, lacking of resources, and it becomes very difficult to take care of a loved one. The nursing home is a resource there. Hospitals won't keep people more than 1 or 2 days nowadays, if they'll even take them at all. And so there needs a place where folks can rest and you know, to convalesce, as they used to, the convalescent center, but also to become, you know, really strengthened and trying to return back to that lower level of care is the intent there. How does you know, because ultimately you talked about, you know, having a physician there, that ultimately came true for you, that you were able to be a physician in a nursing home after you graduated and you finished your geriatric training. Tell us how that came about, and what were, you know, the results, the benefits, and also, you know, being involved in nursing homes. We'll talk some more about COVID, but yeah, again, just what is that transition that you were able to be a doctor in a nursing home, just like you had envisioned?
Yeah, you know, for me, after I finished my fellowship, you know, the typical nursing home physician job was that a doctor would just go to as many nursing homes as possible, and you know, really wouldn't spend much time with the patients. And so coming out of fellowship, I really didn't want to do that. I knew I wanted to be in nursing home medicine, but I really just wanted to hone in on either being at 1 or 2 facilities. So after I graduated, I actually became a hospitalist for a couple of years until opportunities came available.
Now, people don't know what a hospitalist is either. What's a hospitalist?
Yeah, that's a whole nother conversation. But yeah, I mean, as medicine has evolved, the job of what's called a hospitalist, where a doctor is just in the hospital taking care of hospitalized patients as their full-time job.
Yeah, they don't have their own clinic. It's not the classic model where it's a family practice intern. You know, they've got a clinic, and then they'll have privileges up at the hospital, and they follow their patients. But because of the complexity and scheduling and all this kind of stuff, there has to be folks, these hospitalists, these docs that are just there, just working on the flow in the hospital.
Yeah, exactly. So, you know, there became this movement that it really made sense for a doctor to be in the hospital, taking care of the patients and addressing their needs in the hospital while they were hospitalized, and then have them go back to their primary care physicians after they were in the hospital. So, you know, really that model was what I appreciated, that the nursing home didn't have either, you know. And so kind of similarly, that hospitalist type of scenario was what I kind of desired for the nursing home.
Okay. And so you were able to develop that or create that or be a part of that with another company that you worked with, that you were able to, you know, and what did that look like? What were some of the outcomes that you saw when you were able to be a full-time physician in a nursing home?
Yeah, so interestingly enough, as I was kind of seeking out what that looked like, there were nursing homes that wanted to improve the quality of their care by having a physician on site. And so they started programs to do that, and I became an employee of a nursing home company at the time. Also during that time, we see this shift in medicine where hospitals were becoming more accountable. So when they discharge patients either to the nursing home or to home, there became the penalties that if patients bounce back to the hospital for similar conditions, that the hospital would be penalized. And so it really put nursing homes on the map to work with hospitals about reducing readmissions. And so it became more important to have clinicians at nursing facilities to help with bounce backs to the hospital.
Let me just explain that cycle a little bit, just for everybody, these bounce backs, because again, it's traumatic for residents and for our kapuna to transition from one level of care to another. Each one of those transitions, there's a cost to that, you know, either up or down. They again, much at their lowest level of care, if practical. But the problem is okay, they get into this situation where they're sick, and then they become not well enough to go back home. And it's just sort of this, it can become a cyclical pattern of in and out of the nursing home and the hospital. And the folks say, hey, this bounce back, it causes, there's a lot of cost, but it's also a cost for the residents and for their well-being. So we need to stop this, because this is our measure to say that this is a quality situation if they don't go back to the hospital after they leave the facility or the nursing home. So the need for a physician or someone who was thinking through all of those processes and making sure that we did have a smooth transition is something that you were involved in. Mm-hmm. Mm-hmm. How has that changed the marketplace or the environment with that as that concept you participated in, and is it becoming more popular that physicians are now in nursing homes?
Mm-hmm. Mm-hmm. Yeah, I think, I mean, first and foremost, as a physician, I think you have to have a heart for the nursing home patients and residents who are living in these facilities, and out of that have kind of the mindset that you want to bring services to them and allow them to get quality healthcare in the environment they're in, and so that takes a certain type of physician who wants to do that, and right. I would say that the trend really is that not that nursing home medicine is the top.
Listen, it's job. Not glamorous. It's not glamorous. You're not an ER doc. They're not going to make a sitcom. Right. They're not going to make a drama series about it. Okay, right. Probably not.
Right. Exactly. Okay. So, but I think from a standpoint of changing the nursing home physician job of going to so many facilities has changed to where you can be a physician and go to a few facilities and provide quality of care to them, and line up with facilities that also want to provide quality of care, and partner with them as a medical director in their nursing home, and getting the appropriate training to be able to be successful in the nursing home takes some time. And the nursing home world is a very highly regulated environment. And so it really takes, some time to get used to all of the things that are important for not only the residents and the nursing home patients, but the facility has a lot of things that they need to do as well to make sure that they are compliant. And a doctor in the building can be a very good resource to making those things happen, in addition to providing that level of quality. So as nursing home physicians kind of continue to be more involved with facilities, I think we see there much more of a collaborative relationship that makes it more important that the physician is there on a regular basis, so that those things can be worked on together as a team. And I think that's what I enjoy a lot about working in the nursing home world, is that the physician is a piece to the whole interdisciplinary team of a nursing home.
Sure.
And the medical director as well, and being a part of that team when the nursing home physician is on site on a regular basis and invests in the community there, invests in the facility and the people who work there, who also have that love for this patient population and the elderly in the kapuna. It really just makes the job that much more enjoyable.
Well, and speaking of medical directors, as newly the president of the Hawaii chapter of the American Medical Director Association, is that correct? AMDA?
Yes.
Yes.
Yeah. Fortunate to work with some amazing mentors over the past several years, and being a part of the Hawaii chapter of AMDA, which is our national organization. I've had a chance to do some teaching for medical directors through our national organization, and then locally being a part of our board of directors over the past several years, and then just this year starting to learn the ropes of what it means to be the president of the chapter. So still learning, but definitely excited about getting more involved with more nursing homes and their medical directors, and being a support to medical directors across the state.
That's awesome. That's again, not that you don't have enough to do already as you're seeing patients on the Big Island, taking care of palliative care, hospice patients, as well as other geriatric folks out in the community, and staying engaged as a physician and continuing to practice. It's awesome. But and again, as you go into these nursing homes and having that high presence physician model, tell us how that's what you've seen, or maybe the difference, or even if at all, what you've seen as a physician who works in nursing homes, the incredible challenge that the pandemic has created for nursing homes, for the senior care whole profession, and for all of these folks. I mean, it's just, there's been local stories and all kinds of things that all of us have been impacted in some way or another. But what, kind of your view as you woke up that day and said, oh, we're in the middle of it. And then sort of as we're coming through and we're heading out, what are some of the things you see? Let's talk about it.
Yeah, I think, the pandemic has really made us in the nursing home world just really kind of rethink a lot of different aspects of what quality care means. One is just in the complexity of the patients that we have in the nursing home, and how easily susceptible they are to picking up infections. A lot of them are immunocompromised and could easily, tip over to having to go to the hospital because of an infection like COVID very quickly. And so as the pandemic evolved, even diagnosing it was a challenge at first, and getting testing into the nursing homes. A lot of times we had to send patients out to even get a test to find out if they had it.
And then a week later getting the results.
Yes, and having to wait for those results.
By then, it's already, we realized, it had, again, I'm not the expert, so I'm gonna stop and I'm gonna let you talk. But again, our understanding was unfolding on a daily basis of what this really was we were facing, it appeared.
Yeah. So, the accuracy of initially having a diagnosis, and then, not having any real treatment options at the forefront. And so the newness of a pandemic and infection, and it exposing, our fragile and frail elderly in the nursing home. And I think the biggest eye opener was in the Pacific Northwest, where COVID just really went through a nursing home and caused quite a bit of concern about one, that everything was being done to prevent infections from coming into the nursing homes, but also that it led to a lot of death out there. And so that then triggered, really the concern about the nursing home, that they were doing everything possible, but that from the nursing home side of things, having a very limited resource, or having limited resources to be able to address this pandemic. Most nursing homes across the nation are not private rooms. And that in itself is a huge infection risk from a respiratory standpoint.
Sure.
And so, an infection coming into a nursing home is catastrophic. And from the Pacific Northwest to then across the nation, and then even here on the Big Island, this past year, having our own outbreaks that led to a lot of people getting COVID in the nursing home and passing away. So seeing that happen, just heartbreaking to know that, the nursing homes as hard as we have tried and as much work as we have put in, there still is a lack of resources in supporting, how to best manage and take care of this population through such a pandemic. And so it caused a lot of individuals to kind of second guess what is happening in nursing homes. And in the same respect, it also triggered a lot of people to want to be as proactive as possible and try to figure things out. And so I think between the hospitals and what they were trying to provide and the nursing homes, I think early on, I think the hospitals thought maybe the nursing homes could help, have some of their patients go to nursing homes instead of being admitted to the hospitals and backing up the hospitals. And, there was a lot of question about the appropriateness of that. And then, having a COVID patient in a nursing home was a really big topic, and what to do in those situations and how to manage. And so, as medical directors of nursing facilities, just being able to work with your team and figure those things out in the early days. And, we've come to the point of, having a vaccine now that had emergency utilization approval, and then just this week, FDA approving it. Just seeing that the implementation of that and how that has affected the nursing home residents, and being that next level of being able to provide quality to them and try to prevent them from getting this disease.
Well, it has been a big factor in, I think, preventing it and not having outbreaks in the nursing homes like we had initially saw. And and these aren't just anecdotal evidence. However, there is this now with everyone. We thought we were just about through with this, and we were ready to all take off our masks and jump, and which we did. Actually, we all took off our masks, and we invited everyone to Hawaii, and they all came. It's like they were all saving up their vacations for like the last 2 years or whatever, and so everyone was going to do it one right after another. And so all the booking agencies and the airlines, and everyone was real happy. Hey, we've got lined up for a couple of months now. This is great. But then it was a challenge on resources, and all of a sudden, boom, we've got this new variant that, again, I'm not a physician. You are. I don't even play one on TV, right? But okay, you are, sir. And so, what's happening with this new variant, and what are the recommendations that we should? Well, let's talk about the seniors and things. Maybe what's our best approach going forward as we're trying to get at least in regards to the vaccine, or again, recommendations.
Mm-hmm. Yeah, our elderly are the most vulnerable out of everyone. And, I have always been a big supporter of the flu shot, primarily for our kapuna and our elderly, because, even if it is only 60% effective of preventing the flu, if it prevents, one nursing home resident from getting the flu and having to go through that, even if it's self-limited, even if it doesn't lead to them passing away, it to me, so worth it. The vaccinations for the flu have definitely prevented people from having to go to the hospital. And in the same respect, the vaccinations for COVID, the rates that we're seeing of preventing last year, just the regular COVID, and now the Delta variant, it has been effective in this population. It has been working, and it has prevented the spread of COVID. Now, the Delta variant has obviously been the top of the news lately because it is much more contagious and gets spread much more quickly. But that being said, the vaccine has shown that there is less, the hospitalization rates, the death rates are tremendously different between those who are vaccinated and those who are not. And for our elderly, for our kapuna, we want to keep them out of the hospital and having to go through, being diagnosed with COVID. So, the vaccinations really are the key for our nursing home residents and patients to really get through this time, especially during this huge spike. And we are seeing the data show that it has been effective against the Delta variant.
Yeah, well, and then again, everyone's got opinions about vaccine, not vaccine, that kind of thing. I got vaccinated because, again, I work in healthcare. I want to keep myself safe, and again, it's not anecdotal anymore. The effectiveness, even of just one shot, of some of these is similar to that of the flu. Again, I'm not an expert, but again, these are sort of statistics that we know. But it does. Our goal is to protect our kapuna. So there's the vaccines, but then we're also, it's a challenge though, and we're trying to allow as much as possible. But there's this access to their family members becomes a challenge inside a nursing home, because if they're not vaccinated, or if they can still come see families. We're still encouraging visits to come see family. But when there's a big spike like this, there's a risk. Sometimes we want to reduce the amount of time we're spending just till this blows over. What are the expectations? What are they saying? Again, we don't want to take it too lightly that, oh, this is going to pass and we'll onto the Lambda variant or whatever. But what's happening, what you're seeing right now, and maybe the light at the end of the tunnel?
Yeah, I think that one of the hardest parts is that family aspect of having to shut down a facility and limit visitation. I think a lot of us have maybe seen on the news, how do you go visit, your elderly grandparent in a nursing home, and they've put up shields and they've put up, blockades and things that have allowed some sort of visitation, usually outside in some respects. But, when these spikes happen, we can't guarantee that we're not exposing our kapuna. And so the best thing for our facilities to do is to take that out of the equation. And that, unfortunately, is hard to do when we want there to be family interaction. We want there to be visitation. And it's a very lonely place unless you have things in place to really try to bridge that gap. And, we've seen the tremendous influx of having interactions through the computer and through
the telehealth and
telehealth
Zoom calls and FaceTime.
Yeah, so we've really seen that increase, and it has helped. But in the same respect, it's still really hard to know that in the nursing home we have to take these extreme measures to protect our kapuna. And so vaccinations will do a great job the more that people get them. But that being said, when we have things like these spikes, we do have to revert back to the safest things possible. And it's concerning. And, we do make those changes in policies to try to, again, keep them as safe as possible. The hope is really getting up those vaccination rates so that
absolutely
that we can, go back to a more reasonable visitation policy and allow family members to come in and have those interactions, so that there isn't that concern of spreading, COVID. So.
Yeah, so very difficult time for everyone. It's also made folks think, okay, and I think it made a lot of people made the decision if they had to go into if they had to go get some sort of special surgery, or they had to go into the hospital and go to the nursing home, they'd rather take them home so that, because they know that they weren't going to be able to interact with them as much. And so that becomes a challenge as we're trying to continue to fight this. But again, we continue to try and offer as much as we can, using protective equipment if we need to be able to have this connection, because such an important part, this, the social part of our human spirits. Even when we get old, that's, you can still feel alone and lonely. And so again, we want to wrap our arms around them. And if families can come and be a part of that, we certainly want to continue that. And so nursing homes, there's been ideas and thoughts, maybe, well, nursing homes may not be the way that we should be taking care of our kapuna in the future. there's different models that are out there that try and say, okay, maybe this is what it should look like. In your experience, and as you're sort of on the forefront of this type of care, what kind of things do you see in the future, or what you would like to see in the next, again, 10 to 15 years as we go through, as we actually now assist the baby boom through this little space and time here?
Yeah, I think that kind of leads into my other, I guess, specialty, which really is in palliative medicine and palliative care and hospice. And, palliative care really focuses in on really what kind of goals do we have towards the end of our life, and focusing in on figuring out not just treating someone for their disease, but really figuring out what does that last chapter in their life look like. And I think most elderly would say the last place that they would want to be is a nursing home. And as much as that breaks my heart in some respects, I understand why. My grandparents would have wanted to be around their family. They would have wanted to be at home. Right. They would have wanted, if they had a choice, they wouldn't want to go to the hospital. And so those discussions have been happening a lot more. And providers are able to kind of put this scenario into play to give an opportunity for our kapuna to really talk with us providers about what they really want. And most of them, don't want to have medicine given to them until, the last minute of their life. Right. They want to be, like I said, surrounded by family and friends and in a home environment. So as a medical community, how do we make that happen, and how do we put pieces together to help that? And there's been a lot of advances to start that process. And there's so many opportunities for us to really partner with the health organizations, home health, assisted living, and all these different environments to really figure out what that priority is for the elderly, and trying to make that happen, putting their needs above what we think their medical diagnosis needs. And that's really the important piece of having that discussion, figuring out what their priorities are, and then lining that up with knowing that we can provide them care in their homes. It's just a matter of figuring out how to do that and bridging the gap with resources. So there's lots of things happening that are exciting moving forward, and it all starts with kind of that discussion about priorities.
Well, it's interesting. I believe it was passed in the recent budget that there is a added Medicaid benefit to have that discussion, not necessarily about hospice or again, but about your end of life decisions. That because again, if you don't, why are we so afraid to talk about it, Doc?
Yeah, I think that there's cultural aspects, there's religious aspects, there's the fear of the unknown too, and a lot of those things are really difficult for families to discuss. They're difficult for physicians to discuss, and in training, we learn about fixing people.
Do no harm. So the whole idea of guiding one as some sort of soothsayer through the death experience was not part of the training in medical school.
No, right? No, not at all, not at all. And physicians are not comfortable not treating, and that's the reality, that they've been trained to figure things out, to keep going, to keep offering the next step of what can be done to try to treat your disease. And so my hope is to kind of provide more education to providers and to physicians as well about having those discussions, being more comfortable with, if they don't feel comfortable doing it themselves, by consulting a physician or another provider that does have some experience in these discussions, and being able to guide people through the process of seeking the treatment that they really want, and And a lot of the time those discussions don't happen because they're so focused on treating the medical problems.
Yeah, treating the medical problem, but there's this it's the elephant in the room, 90-year-old grandma, where I'm treating, all these things, and should we get the hip replaced? Again, I don't want to discount at all the life and the what people want, and if they're 90 years old and they're spry enough and they're healthy and they can, but again, there's some decisions that need to be made. And so what do we call it? Informed consent. I don't think we give enough opportunity to let them know what choices that they have available to them. They don't even know what it means to die, because again, it's just medical. And then I'm in a, they don't know that whole process, how that, or it can be clarified and they don't know how to clarify it. So what are some of the steps? Well, if someone needs to say, I want to plan the comfortable way that I want to pass, and not saying that you have this death wish. It's not a suicide thing. And that's why maybe people get weirded out about it. It's more, hey, this is inevitable, right? Can we all agree on that?
Right.
So if we can all agree on that, then we should somehow, put some thought into the fact that, this is maybe, I think there are other cultures that have provided lots of avenues and opportunities to express ourselves through that process. But this medical sort of model has sort of crashed onto the top of it and sort of forgotten this whole aspect of this natural passing that is part of our experience. I don't know how to bridge that. Any thoughts?
Yeah, the hope is that our providers, physicians will at some point in time stop that or start that conversation. Now, whether it's just a matter of addressing an advanced directive, which some people call a living will, to start the conversation and say, well, what's going to happen the day that you're not around anymore and your family is having to kind of figure out what to do moving forward? That extending into, really their health conditions and how, what their wishes are. There's lots of different organizations that have put things together to help have those conversations. And really, the more that there's an open line of communication with patients themselves and residents themselves, rather than, a provider kind of dictating the conversation, usually lends itself to more of those conversations. So, open-ended questions from providers and family members about that last chapter or stage in life, and opening up that discussion is really an important piece. And from a provider standpoint, looking at, our own patients and saying, hey, who might not be around in a couple of years? Like, who would I be most concerned is kind of starting the pathway downhill, and, even just addressing the question of, how are you feeling about your medical conditions and what that might lead to? And so,
right.
Those open discussions.
It elicits a response from them, because again, if someone, I guess and this population too often defers to the physician in the medical field, right? To, what do you think, doctor? Or what, I'll wait till the doctor tells me what to do. Well, no, this is different, right? Now we're asking them to make this decision.
Yep.
So it's very different.
Exactly. Yeah. And I think it's hard for a physician and a provider to make that switch. They've been really trained to go down the pathway, and even more so that the quality metrics and things that they are kind of being held accountable for are really in treating patients and not necessarily looking at their goals of care. And so, my hope is that as more quality metrics and things get imposed across kind of the medical continuum, that there will be priorities as far as those discussions are concerned, and that they will take precedence over, talking about the latest and greatest medication treatment for their disease.
Right. It just reminds me, talking about this again, sometimes, again, it's inevitable death. And I remember I studied gerontology in school at Weber State, and one of the exercises we had to do was to plan our own funeral.
Oh, really?
Yeah,
Wow.
it was, planning, who was, and just everything from the beginning to the end. And again, it sort of puts it in perspective that, this is inevitable. It's okay to think about it. It's okay to talk about it. How do you want, oh no, I think there's some fear that if you talk about it, it's going to happen, like knock on wood and salt over your shoulder. And, so, it's a little bit superstitious about it, talking about it. But again, most cultures have an openness that we've lost. And like you say, just it's open-ended questions, opening the conversation, trying to, because what do we know? Well, as you've dealt with seniors, have you ever run into someone that you've worked with or you've been the physician for that has just really surprised you, just sort of continued to motivate you? Someone that stands out in your history. You don't have, we don't share names related to HIPAA and things like that, but a character that just like, man, this really makes me want to continue to do this.
Yeah, I do remember in part of my geriatric training having an experience with an outpatient geriatric clinic and an elderly man who had a lot of experience in running marathons and had actually done the Honolulu Marathon. And knowing that somebody at his age was able to do a marathon just really inspired me from a standpoint of, somebody can be functional in the later stages of their life and still, have a great quality of life. Mm-hmm. And it's not necessarily dependent upon, them getting their medical conditions treated, by the most medications. There's a level of health that people can obtain in their later years, right. and
reduce some of that medication off.
Yeah,
and
exactly.
It's reversible until maybe it's not as dramatic, but if you implement some of these, some of the recommendations, again, physically, depends on, you can make some recommendations, but you can reverse actually this aging in a way, or some of the debilitating effects of it pretty quickly too.
Mm-hmm. 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 Yeah, definitely. And you remember those inspiring stories, and I mean, we hope that for most of our patients as physicians and providers, and I think on the other side of the coin, you've got those who are less fortunate that need the help too. And it's really, again, coming back to addressing those things that are a priority for each individual, and really looking at it from a standpoint of how can we accomplish what you want in your life. And there's ends of the spectrum. There will always be people that want to be treated until the last day, and they'll still go to the hospital, and they'll want, and there's a certain personality type that goes that direction.
Sure.
But there's just as many, if not more, who don't want to go that direction, and I think as a medical
don't want all this invasive stuff happening to them, that they want to go it's more naturally. Is that how would you describe it?
Yeah, I think I think more in alignment with what their priorities in life are.
Right.
And so, they would much rather have a priority be that they spend time with their family, and that they're not in the hospital, and that they're not treated with medications. And if they live their life that way their whole life, then why should it change at the end of their life when they may not be able to make those decisions for themselves, or they may not be in a condition to really understand or realize it. And unfortunately, our default is that we will treat as opposed to we will line up with what we believe that their goal there was at this point in time in their life.
But there are home health companies and hospice companies out there that get this vision, that want to support people through these transitions outside of a nursing home. Mm-hmm. And they're there to support. And again, I think there's a lot of motivated people and organizations to support Kupuna. There's still a group that has brought all of these sort of resources together to sort of align all of these different things and really help and focus on these health impacts that we can watch. We can tell some things if they have certain. We have so much data now about people, good or bad. We can really tell if they have certain types of intervention earlier, they will see less hospital stays and they will see less types of things. Or if they have a little extra time in the nursing home, the return to hospital rate can go down. Some different things that, again, there's ways that we can map all this out and try and figure this out. How do we get everybody to the table? You're a medical director and part of the national. What is the challenges of bringing all these resources together for our nursing home residents and patients?
Yeah, I think it really takes people who want to bridge that gap. I think we kind of get stuck in our silos, and I think nursing homes were there many years ago where no one understood the regulations and they kind of had to function on their own, and really it was just trying to help out the hospital as much as possible, but never being collaborative. And so I think the way that things have progressed is in our healthcare system, having bigger vision of integration across care sites. And that is really figuring that out as one piece. You've got providers, you've got insurance companies, you've got hospital systems. They do have people that are being put in place to bridge these gaps. And that's really what it's about right now is making sure that whatever organization that you're a part of, that there is a hand that's extending out, whether it's 1, 2, 3, or 4, and whatever direction, if it's to the hospital, if it's to the hospice, if it's to the nursing home, to the care homes, it's really trying to understand where our partners are at, what their needs are, and then collaborating to form some sort of interlinking that will allow us to communicate better between care sites, and then have that big picture understanding of what that patient wants for their care across this continuum.
Right, and so that we know that, because a lot of times if they go from one entity to another, these two entities don't communicate, and so sometimes there's misinformation from one site to another. Like again, but now they're centralizing people's medical records so that people can, authorized individuals can access these things from across different areas. Technology is beginning that we've learned over this last, not just with the telehealth, but again, bringing all of this information together, tracking and trending and things like that. This seems to be, technology is invading everything, even healthcare. Is it even invading the nursing homes?
Yes, it definitely is. And as much as the electronic medical record was the solution to not being able to read doctors' notes, it has come with its own onslaught of confusion and
trying to find the doctor's note.
Yes, and and a new world of trying to decipher, typing now instead of just doctors' handwriting. So,
right.
And so many different systems and the interoperability between these systems, still being figured out, leading to still there being a disconnect that, as much as the intent was to have a system that really integrates across care settings, privacy and keeping things confidential is still a very important piece to the equation. But in the same respect, it's a barrier to that communication between different care sites and communication between providers. And so that has been a work in progress, will still be a work in progress, and nursing homes are having to deal with it as well in trying to keep up with the hospitals and their electronic medical records, and our nursing facilities don't have quite the same budget as our hospitals, and so they have to make difficult decisions with making the financial side of things work too. So there is technology that they're bringing in to help, again, smooth some of these things over, and again, the ultimate goal is to provide, I wouldn't say smooth them over, but again, to help
again, this integration continues, so that when the communication is faster, we know that the medications are the same, last week to this week, or when they were in that other location and they were at home, and when they came home, they were here, they were getting the same medication. There's so many things in their, being able to track that while throughout their entire, stay, or not stay, but, as throughout their basically senior care life. I guess, when does that start? When do you get old enough to become a senior?
That's, I get asked that question all the time because, it used to be once you hit 65, you think about retiring, and then there's this mentality that, oh, I'm geriatric age at 65, and I have to correct people and say, I typically don't take care of people until they're 80. And that's where we have the workforce enough to address the over 80 population, and we're still limited in the geriatric field to provide provider services for that age group. So if we
physicians, nurses, and CNAs, right? All the support resources for these folks, challenging right now.
Yep, definitely.
So how do you see that, for providers anyway, how are you looking to develop, people to keep doing this kind of work that's so important for our kapuna here in Hawaii?
Yeah, I think the more that we can provide some education on what it looks like to have, as far as physicians are concerned, a practice that addresses the needs of the elderly, and that how rewarding of a career that can be, and that that it really is not just about being a physician, but being a part of a community, being part of a system and a support system that really is interdisciplinary. And that's the more that becomes a team approach and involves a lot of different disciplines across the board, the education that happens across all different disciplines within medicine for geriatrics is such a unique skill set that once people learn and are educated in those roles and in those fields, I think they see how rewarding of a career it can be. And it's really about communicating that to those who have an interest in helping develop that, investing in the CNA who wants to become an LPN, who wants to become a registered nurse, who wants to become a nurse practitioner, or wants to go on to medical school, and educating along the way to help the workforce, and encouraging them to really take what they love and continue in the process of learning more and expanding their skill set.
Yeah, everyone has to be on a path. You're a great example that, you've become this, you've sort of followed your vision and created a vision for yourself, and become this physician. Are your mom and dad proud of you?
Yeah, I love my parents, and I think, they are getting up in their years, and I recently had a conversation with my mom about kind of addressing that aspect of what her goals are in life, and goals of care and things like that, and had her start kind of thinking about the process. And I must say, it's not an easy discussion with family. I feel like I have, it's almost easier with my patients to go through that conversation, but it's a needed conversation. And, they appreciate what I do, and tap into to my advice every once in a while on issues that come about, and I appreciate that. And I think over time, I just want what's best for my parents, and want what's best for our kapuna, and I think there's ways that can happen, and we're heading the right direction.
Yeah, again, and now you're thinking about the same sort of future for your parents, looking at a nursing home. I had to have the same conversation with my mother. Maybe you could give her some advice. No kidding. She, again, I think people get this idea, okay, I'm 75, which is young, right? Still, I said, remember, Mom, my grandmother, your mother, lived to be 84. Okay, so that's another 10 years from now. if I may have even got the number wrong, and forgive me, Mom. But yeah, there's still time where things can still happen with the body, and there's a whole new there's another potential chapter out there for folks, and so that's maybe a little scary. People don't want to think about it. They kind of put it outside of their thought process.
Yeah, I agree. It's yeah, I think everyone's perception of what they thought things would be like when they're 75 or even 85 and 90s and 100s, and as they get older are it's for some people it's just unknown territory that they don't even really want to go there till they get there, and
right.
I think for some people they like to plan too much, and they've got their retirement plan figured out, but part of that doesn't incorporate things that happen along the way, and obviously COVID's a great case in point about that.
Yeah, as a doctor, I'm sure there's no guarantees, right? There's the things happen with the body every day. There's accidents, of course, but then your body does things. You may know there's things that's going on in your body that you inherited that you still don't know about, that's going to express later or whatever. So again, it's all sort of each day is definitely a new day.
Yep, definitely.
Yeah. So again, it's awesome having you here with us. But before we let you go, we kind of relax a little bit. We want to find out about you, and over there hanging out in the big island. We call it a Palhana, where we kind of just chill a little bit and find out. So first, though, I got to know about when you were young. We still want to know more about that.
Yeah.
Band or sports? Yeah.
I was more into sports.
Okay.
But
what was your pick? Did you have it down there in Southern California, San Diego boy?
Yeah, so I was not a varsity of anything. I would
join a club.
More jack of all trades. So kind of JV at everything. So from golf to wrestling to volleyball to surfing to just I so many interests in different sports. I think that's why I went into sports medicine, was to initially look, obviously, like I said, into physical therapy, but even athletic training and things like that, because I did enjoy sports and being involved, even though I wasn't the greatest. And so yeah, definitely sports over band.
Well, and nothing against band folks. I played the tuba, not very well. I'm still working through that, but so awesome. So then that what what's the pull to Hawaii? How'd you get all the way over here? I know it was in being practicing as a physician in a nursing home. Yeah. It sounds like, but what's keeping you here? It sounds like you brought that surfing hobby along with you. Tell us a little bit about that. And it sounds like you've got some boys that are picking up becoming watermen as well. Yeah,
definitely. Since coming to Hawaii, initially we came to Oahu, and I did my fellowship training, and since have moved over to the Big Island, and got 3 boys and a daughter, and our weekends entail being at the beach and engaging in whatever water activities are available, and so that is dependent on how big the surf is these days. So bigger surf, break out the shortboards and head out into the water. So yeah, the wonderful place that Hawaii has been to us. We have a wonderful community here. My wife loves it here. My kids love it here. And yeah, for sure. So my parents moved away from Southern California, and so did my wife's parents. And so California really isn't home anymore. So Hawaii is 10 times better. So
yeah, and Kona is beautiful. And but as a physician too, maybe you're not always, you have opportunities. We had on the podcast, Lieutenant Governor Green. He said, he's traveling over to Honokaa on the weekends or North Hawaii to do some some weekend ER work and stuff. So docs around here, they travel, and they probably hit every island. Is that right?
Yeah, there's a lot of inter-island specialists that go to provide services. I mean, on the Big Island, we do have a lack of resources as far as specialty physicians, and it's not that uncommon that we have to ship people over to Oahu because their medical conditions are can't be taken care of over here. And so that adds a different dynamic to being a physician, especially Outer Island, and as far as resources are concerned. And so, yeah, it's the physicians that do come out here do have a heart for serving, the Outer Island and the population that doesn't have access to specialty services. So we're fortunate to have whoever decides to make that trip. And I was one of the ones that was doing that years ago. And fortunately, right now I'm not doing much traveling and fortunately can do a lot of things remotely. But yeah, it definitely is island life out here.
Well, yeah, hey, it's not too bad. Oh yeah, I'm tough, and I got to go do some duty over on the Big Island. Hold on, I got the weekend too, So there's maybe some complaining, but again, it's out of the goodness of their heart, but also, but that's a real issue though too, and we could probably spend a whole other thing about all the specialists and things that Hawaii is lacking and different things, but that's for another episode, I think. But Toby, we are so excited that you came and visit, or we came over to the Big Island and saw the boss right in his office and found out a little bit more about everything you wanted to know about nursing homes, but we're afraid to ask.
Awesome.
And so we hope to, as things progress and as we get through this COVID, and we'd love to have you back on and talk some more.
Yeah, definitely. Thanks so much. Appreciate the time.
You bet. Take care and aloha.
Aloha.
Make sure to subscribe to Hawaii Boss and follow us on social media at Hawaii Boss Podcast at the links in the description. We'll see you soon in the boss's office.